Hi everyone. Let's begin with the next part of the RNA viruses, and that includes the arbovirus. If I break the word arbo, it brings it very clear to me that AR for arthropod, this is arthropod bone viruses. So definitely a lot of arthropods that I will be talking about over here. So these are the 5 organisms or the families that come under it: Bunya virus, Toga virus, Flavivirus, Rioviridae, and Rhabdoviridae. I'm sure you heard of these viruses elsewhere also. I have only taught you. What I taught under rhabdovirus was rabies, so rabies is not arthropod borne. But there was another member in rabies that was known as the vesicular stomatitis virus, and I hope you remember this was associated with sandfly. So yes, that is arthropod borne. Similarly, there's a family called Rioviridae. Rioviridae reminds you of rotavirus. Rotavirus, the one that was causing diarrhea, that was not arthropod borne. But Rioviridae also had another one called Colorado tick fever, and that is definitely arthropod borne. Then we had Flaviviridae. Flaviviridae is the one that you'll hear most commonly. So we have things like Japanese encephalitis, yellow fever, Zika, dengue, West Nile fever. You know, all of these are going to be arthropod borne. In fact, there is something in Flaviviridae family which comes under a hepatitis. Which hepatitis is also under Flaviviridae? Hepatitis C also comes under it, yes. Okay, moving on to the next, we have the Bunya virus and the Toga virus. What all comes under the Toga virus? Toga virus has 4 things: rubella, chikungunya, eastern equine encephalitis, and western equine encephalitis. The way of learning Toga viridae family is going to be the Tonga car. Everyone's seen or has sat or has just seen this in movies, or at least somewhere you've seen a Tonga car. So what is it in a Tonga car? Tonga car is always associated with a horse. That's the horse that you can see. And there's a car which is attached on the back side of it. So firstly, the Tonga car is going to remind you of the Toga viridae family, right? And the horse will remind you of all the equine diseases that you have, like eastern equine encephalitis, western equine encephalitis. And car will remind you of rubella and chikungunya. Car will remind you of rubella and chikungunya. So coming back, we have the equine, western and eastern. Then we have car, that is chikungunya and rubella. They come under Tonga car, that is Toga virus. And finally, we have something called a Bunya virus, and Bunya virus further is going to have many features. So I've decided to put Bunya virus, and I'll start off the story actually with Bunya virus only, and I'll put it up on a separate slide. Now, what is it about this entire Bunya viridae family that you can recall? Was it a segmented or an unsegmented? I remember all the Bira viruses are going to have a segment, and yes, that is Bunya. And I told you Bunya looks like a B, B looks like a 3. That is what we had said, that B is going to look like a 3, right? So how many segments did it have in its RNA? It had 3 segments. Perfect. So what all comes under it? It has, of course, the Bunya virus, then the Phlebivirus, then there is Nairovirus, and then there is Hantavirus. One by one, I'll split them up because I told you na Bunya, but in like 5 minutes, this family will be done. Let us start with the first one under it. That is going to be the Bunya virus, and that is going to cause the California encephalitis. So please remember A, B, C, D, E. That is how you learn it. Means when you're talking about the Bunya virus, what does it cause? It causes the very famous California encephalitis. And how is it going to be transmitted? Aedes mosquito. Repeating this entire mnemonic once again. B for the Bunya virus, which causes the California encephalitis, and it is transmitted by the ADE, that is the Aedes mosquito. And of course, no points for guessing that it is an encephalitis, and that is what the patient will have. So Bunya virus and California encephalitis is done. The next member that we have in this family, so dekho, Bunya virus and California is done. The next member that we have in the family is the Phlebivirus. What all do we have? Phlebi में थोड़ा सा F वाला sound है, तो sand fly fever or rift valley fever. So remember the sand fly fever because that has the F wala sound, and the rift valley fever that has the F wala sound. All of them are Phlebivirus say causative. Sand fly fever, any points for guessing? How is it transmitted? Of course, via sand fly. Rift valley fever is going to be again by Aedes, and I'm going to give you a mnemonic in the end for Aedes, which is going to make it very simple. So for the time being, for Aedes, just keep keep going. For others, I'm telling you the mnemonic. So remember, sand fly fever is of course by sand fly, Rift Valley is by Aedes. And what does it cause? All of these are somewhere or the other causing some kind of encephalitis. So fever, retinitis and encephalitis. How I have learned it is, since the beginning, retinitis and valley, that is encephalitis. So we have retinitis, Rift Valley fever, it causes retinitis, and valley ka E, encephalitis, and fever, of course, fever. Yaad rahega? Let's move on to the next one. So what all have we done? We've done bunya, we've done flevo. Now we go on to nairovirus. Nairovirus has the CCHF, that is Crimean Congo hemorrhagic fever, which I consider very important because this happened in Gujarat and it's seen in India. So this Crimean Congo hemorrhagic fever, number one, is it going to cause hemorrhages? Yes. Is it going to cause fever? Yes. So the clinical aspect is clear in front of me. But remember, the primary concern over here is hemorrhagic, means this is H for H. This is transmitted by a hard tick. This is transmitted by a hard tick. This also comes under BSL-4 category, and every type of transmission is known. Animal to animal, human to human. That is why it's under BSL-4. And this Crimean Congo hemorrhagic fever is seen in India. Remember, hemorrhagic hard tick. Coming to the last one is going to be the hantavirus. Hantavirus has something common. There are two hanta related things. एक kidney वाला होता है और एक pulmonary होता है, right? This is known as the Hunter renal syndrome. This is the Hunter pulmonary syndrome. So when it happens in the kidney it causes interstitial nephritis, and in the lungs what will it cause? It will cause interstitial pneumonia. So दोनों में interstitial. Repeating, in the kidney it causes interstitial nephritis, in the lungs it causes interstitial pneumonia, and it is going to be hantavirus. What are the common points between the two? ये दोनों, these two hanta are associated with hemorrhages, and they are associated with rodents. That is the commonality between them. I know it's not that easy a topic, so what I'm going to do, I'm going to go all the way back to this part and ask you some questions quickly. When I talk about bunya virus causing California encephalitis, I hope you remember ABCD. I told you bunya virus causes California encephalitis, and what was the vector? The vector was Aedes. Talking about flebo had sand fly and Rift Valley fever, FF wala. So sand fly fever is of course by sand fly. And do you remember Rift Valley I told you was because of Aedes, and you also remember what were the clinical points? I said RI se socho retinitis, number one. Then for valley I told you think of encephalitis, and fever of course think of fever over here. Sorted. Next we have the Crimean Congo hemorrhagic fever. Kya hai? 1, 2, 3, 4. Crimean Congo hemorrhagic fever, which belongs to the BSL-4, and this is hemorrhagic. So hemorrhage to hoga, but this is associated with the hard tick. Sorted. This is the one that is seen in India. Coming to the two hanta renal, hanta pulmonary. Both of the hanta are associated with rodents. Both the hanta are also associated with hemorrhages. Renal wala is going to cause interstitial nephritis, and the pulmonary one is going to cause interstitial pneumonia. And this is your final flowchart, which you will revise in the last day for Arboviridae family. I can put a tick mark over it. I am now going to go on to the Tongacar, the Arboviridae family, out of which if I say ye dono chota hai, which you hardly get to see in our country, so let's finish them off quickly. So what is it that I'm talking about? I'm talking about the eastern and the western equine encephalitis. So these are associated with what? Remember, eastern equine encephalitis, EEE, they are associated with Aedes. I told you Aedes ka mnemonic end mein karenge. And the other one, western equine encephalitis, is associated with Culex. So one is Aedes, one is Culex. So Aedes mein hi aata hai. Aedes is going to be the eastern equine encephalitis, and Culex becomes western equine encephalitis. No points for guessing that it is seen in horses, and it's pretty mortal. It has a 50 to 70% mortality. So ye zyada important nahi hai. What is important in the Arboviridae family is rubella and chikungunya. I'm starting with chikungunya first. You know, I'll be taking up chikungunya, then rubella, and after this I'll be going on to the rest of this family also. So why don't I just pick one place and put all the incubation periods first? Then the rest of the life for this chapter becomes a little simple. So these are the incubation periods that I've got. Please note, when I'll write Kaisanur forest disease, KFD, when I'll write Kaisanur forest disease, you guys can learn it as Kaisanur forest or 4 for forest and est for 8. It is Kaisanur forest disease. Okay? So now you will never ever forget that Kaisanur forest disease is going to have an incubation period of 4 to 8 days. After that, we see dengue has how many alphabets? 5 to 6. Yellow has how many alphabets? 5 to 6. Chikun, we don't call it, usually if you've seen, they always say that there's an outbreak of chikun. Chikungunya aisa koi nahi bolta. Everyone says dengue fever, dengue, chikun and yellow. So dengue 6 alphabets, 5, 6. Chikun 5, 6. Yellow 5, 6. So if you realize somewhere around all of them are having roughly the same incubation period. Finally, coming to the last one, without a mnemonic, you will learn Japanese encephalitis, 5 to 15 days. So you can just learn 10 days as a median of it, okay, as a center point of it. So Japan में 10. So remember, this becomes an easy one. I suppose now we can quickly revise this one. So please note, Kaisanur forest disease, so 4 to 8, dengue, chikun and yellow fever 5 to 6, and Japanese encephalitis 5 to 15. Okay, now we'll start one by one. I'm starting with the chikungunya virus under Togaviridae family, and this is what we have. How is it transmitted? The vector is going to be the Aedes mosquito, and this is going to have a very famous fever and joint involvement. So these are the points which are important. Dekho, incubation period I want to wipe off now from everywhere. Chikun had 1, 2, 3, 4, 5, 6, so 5-6 days ke aaspas ka hoga. Other things I want to focus on. What is the fever? There's a very famous fever called the saddleback fever. And along with that, guys, so saddleback fever is basically a kind of a biphasic fever that you can say. Okay, it's a kind of a biphasic fever. Coming to the next, there is a migratory arthritis and also associated with arthralgia. Arthralgia means there's very severe joint pains, and this usually involves the small joints. Anything else? So fever and arthritis is like it's, what can I say? It is a kind of a pathognomic thing for this, that you will see fever, saddleback, you will see arthralgia. What else can you see? You can see the chick sign, and you can also see lymphadenopathy. Lymphadenopathy, everyone knows, lymph nodes. Chick sign, you might be wondering. So this is actually a kind of a post-chikungunya, manifestation. Can you see this hyperpigmentation that has occurred? That is a chick sign. So post-chikungunya hyperpigmentation is going to be the chick sign. These are the clinical symptoms. So you have fever, saddleback, you have lots of joint pain. There is a chick sign, which is a hyperpigmentation post-chikungunya. So chikungunya, easy to learn. And finally, lymphadenopathy. How are you going to do the diagnosis? Nothing fancy about it. We have to pick up the antibody. Antibody in early cases is IgM. In the late cases, it is going to be IgG. Because chikungunya is quite important in our country, I also want you to know the timings. So please note, IgM starts off in 4 days and can even be present up till 2 months, and the methodology of measuring IgM is said to be MAC ELISA. Whereas IgG starts roughly around 2 weeks. They start hone lagta hai, but a proper concentration develops later, and it is also available or visible in the blood till 2 years. So remember, IgM, as always expected, comes first as early as 4 days and is determined by MAC ELISA, whereas IgG is going to be seen for many years. Of course, it's an RNA virus. This I will copy paste everywhere till we finish this entire section, and that is reverse transcriptase. PCR is done. Now, so the last member of this Togaviridae, Eastern and Western equine encephalitis done, chikungunya done. Now we come to rubella. But before I start with it, we have till now been studying that rubella is a type of a Togaviridae family or Toga virus. Now they are also saying that it is a type of a Metonaviridae family, or it is a part of the Metonaviridae family. So just put up your question accordingly. If Metonaviridae is not there in the options and you have to select the family, you will select the old answer, that is Toga virus. But if you have to select the latest answer, your answer is now for rubella is going to be Metonaviridae family. So yes, what are the other names? This I've told you. Have I also told you that rubella is known as the German measles? And have we also studied that rubella is known as the 3-day fever? This is, or the 3-day measles. It's known as the German measles and the 3-day measles. So I had given you a cross connection. I told you that measles is not known as German measles. Measles is known as rubeola, not rubella. Measles is known as rubeola. whereas rubella is known as German measles. I told you na, this cross connection that you have to know. Okay, so I've put it up over here. Rubella is known as German measles, also known as 3-day measles. What is the mode? Of course, it has to be the respiratory droplets, which is, what is that vaccine? Measles, mumps and rubella. तो तीनों का ही respiratory droplet का route हो गया, ठीक है? But for rubella, what you also have to know is transplacental torch infections. It's definitely going to result in congenital malformations. So before I start with the congenital, first I'll tell you someone having respiratory droplets infection, what all he will have. Then we'll go on to what a transplacental congenital person will have. So firstly, do you remember the incubation period? Do I have to teach you? I don't think so. I told you for how to learn measles, mumps and rubella. For measles, I told you start with 10 days. Then after that, I told you from the 10-day, make a 9 out of it. So mumps becomes 19 days. And in rubella, I told you from the 19, make a 4. So rubella becomes 14 days. So 10, 19, 14. That is going to be measles, mumps, rubella. Rubella 14 days. Respiratory droplet hua, so it is going to cause an upper respiratory tract infection. And if it causes an upper respiratory tract infection, there is obviously going to be a post-auricular lymphadenopathy also that will be noted, correct? Like all of, it's very similar. Because why are you calling it like German measles, 3-day measles? Because measles se kuch to similar hoga na. What is the similarity between rubella and measles is that the rash. Firstly, the rash lasts for 3 days. The rash lasts for 3 days. Now you understand why is it called a 3-day measles. The rash lasts for 3 days. It is a 3-day measles, and the rash is very, very similar to the rash of measles. Exactly, guys. Do you remember how was the rash of measles coming? It used to start behind the ear, then it was on the face, then it was on the trunk. So exactly measles jaisa rash hai, and it is going to last for 3 days. That is why they called it German measles or 3-day measles. What else? Can I see something over here? Some red spots over here. What are those? Those are known as the Forsheimer spots. These are known as the Forsheimer's spots, and they are seen on the palate. You can see them on the soft palate. They are red color spots that are there. So now I want you to tell me one more difference. When you were talking about measles, you were seeing something next to the molar. Measles mein molar ke paas kaun sa spots tha? You were seeing complex spots, right? And in rubella, what are you seeing? You are seeing the Forsheimer spots. That is something that you have to know. So coming back, I have seen all these pictures. I can see a rash, yes. I can see the palette showing me the Forsheimer spots, but let me tell you, these Forsheimer spots are very, very, very non-specific. The difference is that complex spots were very, very pathognomic and very, very characteristic of measles. They were pathognomic of measles, whereas Forsheimer spots are non-specific for measles. That is what you have to know. Or they are non-specific for German measles, I would say. For rubella, they are non-specific. You don't have to know where else, but scarlet fever may be dikhta hai. I don't want you to know where all you see Forsheimer spots. Not at all important. You just have to know it is not a specific finding for rubella. Okay, let's move forward. You've understood that via respiratory droplet, how it called URTI, rash and all of that. But what is this transplacental thing? So yes, it can go from mother to child. It is teratogenic. So you know this question's answer. Most dangerous trimester. So now I'm going to reframe this question. So if I ask you maximum congenital malformations are going to occur in transfer of which trimester? Of course, that is going to be the first trimester, right? If first trimester transfer happens, it's one of the, because organogenesis occurs then. So it's very, 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 very grave. And it results in a congenital rubella syndrome. Rubella is sounding like rona. Why is someone rona? Why is someone crying? So remember, pyar mein andha and behra. So pyar mein andha and behra is what you're going to learn. So pyar mein andha and no ears. He doesn't even have ears. So there is pyar mein andha behra. So pyar is what? Pyar is hard. That is going to be patent ductus arteriosus. Andha means there is cataract. Behra means there is sensory neural hearing loss. So why is he crying? Congenital rubella syndrome is crying because he is pyar mein andha behra. That is patent ductus arteriosus, cataract and sensory neural hearing loss. You'll always remember rubella, rona, pyar mein andha behra, right? But other than that, I can also see that this child has a very classical appearance. If you notice on your side, this child has a very classical appearance, and that is referred to as these dermal ecchymosis, or actually they say this is a dermal manifestation known as the blueberry muffin baby. This is referred to as the blueberry muffin syndrome or the blueberry muffin baby. And yes, this is a dermal finding that is seen, because of which you see those blueberry wala, exactly those blue spots which you can see without the labelings, which you see, very famous. But blueberry muffin is now becoming a little non-specific because there are other congenital malformations also that can show the same. Let's move forward. This is something which was a recent exam question of how a congenital rubella syndrome baby can excrete rubella virus in his urine and saliva. Remember, in the urine and saliva, this can be excreted for a very long time, that you have to know. Very important finding. Again, this came in the recent NEET, it also came in the INICT, so you have to know. Urine saliva may there will be excretion of what? The rubella virus. If I ask you in terms of the diagnosis, lab diagnosis, again, there is nothing that is I can tell you is specific. I'm going to say the same story again. You are going to do an antigen testing, antibody testing. For an RNA virus, you will do reverse transcriptase PCR, cell culture. There is no culture. We have cell lines over here. So the same thing you will use. And do you have any cytopathic effect for rubella? No. There are no giant cells or bodies and all of that. So there is nothing which is specific or out of the box for rubella. But definitely, because it is transplacental, you have to know what to know out for a pregnant lady. So pregnant lady ke liye, please remember, if you find IgM, that is what is going to indicate a recent or an acute infection, and that is what is dangerous. If there is a female who's pregnant and you find IgG antibodies and there's a titer of more than 1:8, that is not dangerous for the child because that indicates a past infection. So remember, when you look out at a pregnant lady and do a rubella antibody profile, you need to look out if she has IgM antibodies, because that will indicate that she has a current infection. That can be dangerous to the child. If she has IgG infection antibodies, this means it was somewhere in the past. That is not dangerous for the child. Obviously, we also have to quickly go through the rubella vaccine. Live attenuated, anything that is a live attenuated, rather than calling it virus, I would say this is a live attenuated vaccine, and anything that is live attenuated will be contraindicated in immunocompromised individuals. It is contraindicated in immunocompromised individuals. Do you remember the strain I have taught you earlier? RA27/3, because now we always give measles, mumps and rubella, and I had given you a mnemonic. Measles, then mumps I had told you was a cute little kid called Jerry, and rubella ka to R for R. What did I say? Tell me the strains. Measles, mumps and rubella ke liye. Measles ke liye I told you Edmonston Zagreb strain. Edmonston Zagreb strain. So that is why I had emphasized on the Z over here, the Edmonston Zagreb strain. Mumps, I told you, was a cute little kid called Jerry. So that was Gerald Lynn strain. And rubella, R for R, is going to be RA27/3 strain. And that wraps up your rubella as well. So Togaviridae family is done. We are done with the chikungunya. We are done with rubella. Now we move on to the Flaviviridae family. Under Flaviviridae family, the one that we have to know is the famous Japanese encephalitis. So please note, we are now starting with the famous Flaviviridae family. So Japanese encephalitis, dengue fever, yellow fever, all of those are going to come up. Okay? So Japanese encephalitis mein firstly, if you remember, there was an outbreak in Gorakhpur in UP, which was quite famous, highlighted, and a lot of news articles and cases came out in the report, in the news as well. Right, so Japanese encephalitis mein encephalitis to hoga, that is understood. So let me go and focus on the other aspect. Neurological and encephalitis to I will deal with, but other aspect. Who is the vector? The vector is Culex. There are two Culex mosquitoes that you have to learn. One is Culex tritinorincus and one is Culex vishnui. Who of these, which of these, tritinorincus and vishnui, which word is more commonly used in India? Vishnuji is more commonly used in India. So if they ask you which is the more common vector in India, so you will remember Culex vishnui is more common in India, and Culex tritinorincus is going to be common in the world. Easy to remember, Vishnui in India, tritinorincus in the world. Who is the reservoir and the amplifier? So now you need to know, vector to ab ek life cycle banate hain. Vector to I know, ma'am, some kind of mosquito must be there. Other than that, I will see some bird and I will see some pig. Okay? So let me see this life cycle. Yes, I can see a mosquito vector and I know that the mosquito vector will be Culex. I can see a bird. Guys, these birds are nothing but the RD'd birds. These are the RD'd birds. There are many types of RD'd birds. I'll give you an example. Crane is an RD'd bird, okay? After that, we have a pig also that has been shown over here. So one of these, remember, pig is the amplifier host. Pig is the amplifier host, whereas RD'd birds are the reservoir host. ठीक है, whatever word comes in them you will pick up. Pig में P आता है, so that is amplifier, whereas RD'd has RD'd R word is very prominent, so that is a reservoir host, and the mosquito is Culex. So simple. If there is a natural cycle occurring, it is happening between RD'd bird and Culex and RD'd bird and Culex. That is natural cycle. If an amplification cycle has to occur, it is between pig and Culex, right? However, where do we come into the picture? We come into the picture as a dead end host. So if you see this natural cycle, amplification cycle and a dead end host mentioned, they are dealing somewhere between your Japanese encephalitis. Now comes the understood part, encephalitis. So starting में थोड़ा सा fever होगा, then there is going to be features of encephalitis. Simple. So starting में you're going to have mild prodromal symptoms. After that you will have acute encephalitis, and encephalitis means that the patient is going to have a neurological deficit. So the word itself is quite nice, now it explains everything. Now even I am tired of asking you this question. It's an RNA virus. Which kind of PCR are you going to do? A reverse transcriptase PCR. This is such a nice thing. Kuch bhoola nahi bhoola, this I will always remember. But you can do a reverse transcriptase PCR where? Because it's a case of encephalitis. I can do it in the CSF. What is the treatment? There is no drug as such, supportive, or you can say just supporting the patient in whatever symptoms he has. Supportive or symptomatic treatment is what we are going to do for Japanese encephalitis. Treatment के लिए drugs नहीं है, but vaccine is there. There are 3 vaccine strains that you have to know. One is live attenuated, known as SA 14-14-2, live attenuated vaccine 14-14-2. This is the one that is used in India. Other than that, there are 2 inactivated vaccines. There are 2 inactivated. So SA 14-14-2 was a live attenuated vaccine. 2 inactivated vaccines matlab one of them has been inactivated by growing in the mouse brain and formalin inactivated. The other one is cell line derived. तो एक mouse brain derived है, एक cell line derived है. Mouse brain derived is known as the Nakayama and Beijing's P1 strain, whereas Beijing P3 strain is going to be cell derived. You might not want to know exactly which is mouse derived, but I can give you a mnemonic. When I'm saying Nakayama and Beijing, right, versus when I'm only saying Beijing, so which of them is going to be the mouse brain? So you will say Nakayama Beijing, mouse brain wala is Nakayama and Beijing strain, and only Beijing P3 strain is a cell line derived. I hope you all remember that I have mentioned this earlier as well. Do you remember there was something called Nagayama spots, and I told you don't confuse that with this Nakayama strain that you have over here. So Nakayama strain is the vaccine strain for Japanese encephalitis, and where did you see Nagayama spots? Remember there was something called roseola infantum, the 6th disease. The roseola infantum or the 6th disease showed you the Nagayama spots. Let's move forward. We are done with the entire Japanese encephalitis, settled that topic. The next virus that we move on to is the yellow fever. Again, now yellow fever, if I say everything is roughly, what is the incubation period? All these, all these 6-letter things had a 5-6 days or 7 days ka incubation period approximately. Not only that, it has 7 genotypes, whereas it is endemic in different parts of Africa and America. Those are the places where it is endemic, which means anyone traveling from these places to countries like India, because in India we are not having yellow fever. Anyone traveling from these places to India needs to get vaccinated, and I will talk about that in a while. So remember, there are 5 to 7 days mein incubation period, 7 are the genotypes, and it has 1 serotype. Now what I have to know is about obviously the vector. What is the vector for the yellow fever? Again, the Aedes aegypti. So many things are coming with Aedes. So what I'll do in the end, I'll make one list for Aedes, one list for Culex, so that we are sorted. What are the 2 major cycles? There is something known as a jungle cycle and an urban cycle. Common sense, both of them have to have a mosquito in it. The Aedes mosquito. So the jungle cycle will have the forest mosquito, the jungle mosquito of course, and the urban cycle will have the urban mosquito. Okay, this is again common sense. The jungle has the forest mosquito, the urban has the urban mosquito. But what else? The jungle will have the cycle involving the monkeys. Whereas urban cycle will obviously involve us. So simple. Urban cycle is between humans and mosquito, and jungle is between monkeys and mosquitoes. So now starting incubation period, I have told you why 5 to 7 days हमें पता है. And for your revision, I have got you. Dengue has 5 to 6 alphabets. Chikungunya has 5 to 6 alphabets. Yellow has 5 to 6 alphabets. तो सबका 5 to 6 या 7 days का incubation period is set. Okay, now did you ever wonder why did we call it yellow? Yellow in our body, a disease is known as jaundice. Jaundice means there is involvement of the liver. Yeah, that will happen, but not in the initial phase. Mild phases may we start off with things like fever, chills, and myalgia, which probably every infection has, right? Fever with chills and muscle pains. But over here, there is fever with bradycardia. What is that known as? Fever with bradycardia is known as the Fagot's sign. And I hope you remember this is something which we saw in Salmonella also. This was also seen other than in yellow fever, in typhoid fever, enteric fever, right? Over there also fever with bradycardia is noted. Then where is the yellowness coming? The yellowness is coming in the severe form. Please note there is involvement of the liver. So yes, there is hepatitis. In fact, you will realize and you will study in your pathology lectures also that I have taught you that yellow fever causes mid-zonal necrosis. Yellow fever causes mid-zonal necrosis. Very famous question. Which part of the liver lobule is affected? Mid-zonal lobule is affected. And other than that, there are hemorrhagic manifestations also. Something causing hemorrhages means which cell of our body is it impacting? It is impacting the platelets. So it causes a platelet dysfunction. But these are features of your severe disease. Simple. So mild disease is fever with bradycardia. Usually fever has tachycardia, na? Here fever with bradycardia called Fagot's sign is seen. Severe में hemorrhage and hepatitis is noted. So right now I told you that it is not very common in our country, right? So India is basically said to be free from yellow fever. So how do we keep ourselves free from yellow fever? We have kept two things. If there is any unvaccinated traveler who is coming from an endemic area like West Africa or South America, then that person is told that please get yourself quarantined for 6 days because 5 to 6 is the incubation period. If you do not show after landing here, if you do not show any symptoms for 5 to 6 days, then you are allowed to enter into our country, roam around in our country, right? That is only applicable for someone who is unvaccinated. Coming from that area and unvaccinated. If he's vaccinated, if he can show me the certificate, then it's all good. Now we come to what else have I maintained. I know that the vector is Aedes aegypti, so I make sure that the Aedes aegypti index is less than 1 around the airports and the seaports. So around the airports and the seaports, the Aedes aegypti index, which you study in PSM, has to be less than 1. ठीक है, आगे बढ़ते हैं. What is the diagnosis that you will do? This is what you do for everything. Serology is what you're going to do. IgM and IgG, you can say IgM comes earlier within 3 days of onset of the disease and IgG comes later. Cytopathic effect, come on, you know this. What is it that you see in the liver? Which part of the liver is destroyed? Mid-zonal necrosis, this you've told us, ma'am. Okay. Are there any bodies that I taught you way back in the first chapter? Yes, there is something called the Torres body. So note, cytopathic effect mein, number 1, the liver shows you mid-zonal necrosis. Previous year question we have discussed. Second, it shows you, I made you learn it, that yellow fever shows you Torres bodies. Sab mein middle mein, that is now how I will complete your mnemonic. Firstly, yellow, 1, 2, 3, 4, 5, 6. So it's going to be 5 to 6 days ka incubation period. Next, I say that here we are talking about yellow fever. So the bodies that we are going to have are going to be the Torres bodies. And finally, after this, we say that because I'm focusing so much on the center part of it, yellow fever, Torres bodies, it is going to result in a mid-zonal necrosis that happens in the liver, and that is why patient has jaundice. That is yellow fever. I hope it is sorted. You're of course left with the vaccine. Vaccine gets you a lot of questions in PSM. What is the famous yellow fever vaccine that we have? 17D vaccine. So what is it? It is a live attenuated vaccine. How is it prepared? Come on, you know this. It is prepared from the allantoic cavity. So yes, we go back to the first chapter. Have I taught you that allantoic cavity mein I am very much gonna have yellow fever ka vaccine, even yellow fever ka growth. Allantoic mein, if you remember, we had something called YARI as my mnemonic, where I had told you that yellow fever ka, rabies ka and influenza vaccine ka growth happens, hai na? So please note, yellow fever is in the allantoic cavity. Yes, it is prepared. What is the route? It is a single dose subcutaneous. It is a single dose which is going to be given in a subcutaneous manner, and that is a live, I'm again and again saying live attenuated vaccine. Okay, I'll tell you why am I emphasizing on it. Firstly, what is the efficacy? Efficacy is said to be that a response starts by the 7th day. Jitna incubation period hai, 5-7 days, the vaccine also starts working by the 7th day. And that is going to go until 35 years. So earlier they used to say that, you need to get a certificate updated after every 10 years or so, but now that is not said. Now it is said that once you get yourself vaccinated, within 10 days you will get the certificate, and that is valid lifelong. So this is what you have to know, within 10 days. So today if someone gets a vaccine, then after 10 days he will get a certificate of his vaccination, and then till lifelong that certificate is valid for travel purposes. Coming back to my point, why was I saying it is live attenuated and grown in an egg? Because anyone who is having any kind of immunocompromised state cannot be given this vaccine. Anyone having egg allergies, because it is prepared in an egg, so anyone with egg allergy cannot be given. So contraindications, number one, anyone who is pregnant or less than 9 months, chota bachcha ya pregnancy, live attenuated vaccine you can't give. Anyone who is immunodeficient or HIV or transplantation, organ transplant, any immunodeficient scenario, you cannot give it. And obviously, as I told you, it is prepared in the allantoic cavity. Anyone with egg allergy, you can't give it. One more thing. Can the yellow fever vaccine actually end up, kind of interacting with some other vaccine so that these two vaccines are never to be given together? Yes, that is the cholera vaccine. Cholera and yellow fever vaccine interact together to make sure there is a gap of 3 weeks between them. So if someone's received cholera, do not give yellow before 3 weeks. If someone's received yellow fever vaccine, do not give cholera before 3 weeks. So please remember, the gap between these two vaccines has to be maintained for 3 weeks as they interact with each other. Done with Japanese encephalitis, done with yellow fever. Now we move on to the KFD. KFD is the Kaisanur forest disease or the monkey fever. Now what is the vector for this? The vector for this is the heart tick, and monkey of course is going to be the amplifier host that I have over here. Okay, tell me something that did I teach you the incubation period? I said that from today onwards Kaisanur forest disease ko 4-8 yaad rakhna. It is the 4-8 disease. So remember, the 4 to 8 days was the incubation period going forward for Kaisanur forest disease. Okay, so now first I'll tell you this life cycle, because I can overall realize that clinical features mein to kuch naya ma'am is not going to tell me. In all of these, ma'am is telling me fever with chills and muscle ache and hemorrhages. I'll come back to that. So same way, Kaisanur forest disease also, after the vector is going to bite, it is going to result in fever, myalgia, and it is a part of the hemorrhagic fevers. If you feel that, okay, ma'am, but I'll forget what are all the hemorrhagic fevers, I will give you a list, but at the right time. I will give you a list of all the hemorrhagic families and fevers, but this is also a part of the hemorrhagic viruses. So mucosal and cutaneous hemorrhages with fever and myalgia after a heart tick bite. So how does the life cycle look like? So I just told you, vector yaad rakho, heart tick, and monkey, who's the amplifier host, has to be there. So coming over here, you are going to get a life cycle of a tick. I can see a life cycle of a tick going on over here. I can see monkey. So for that matter, you can also see that there are also rodents and there are also cattle that are involved. So either the infection is going to come to me via a tick bite. I can see how is the infection coming to the humans. Focus on that. It is coming via a tick bite, number one. Number two, it can also come after contact with animals. It can come after contact with animals. Person to person, however, is not known. So, bas ye 3 things you have to know, that it's directly coming from the bite of a tick, heart tick, or animal contact, but no person to person. Okay, so now coming back, how is going to be the epidemiology and the diagnosis? The epidemiology, mein remember, ye jo forest wala disease hai, ye first half of the year means January to June. This is where it is seen. So it is more commonly seen in the January to June season. Other than that, in the diagnosis, I have nothing new to teach you. It's the same reverse transcriptase PCR, and the treatment is also going to be supportive. That is KFD, Kaisanur forest disease, monkey fever. Monkey is the amplifier. Now we come to the next and recent exam favorite, and that is going to be the Zika virus. The Zika flavivirus, again another thing that is going to be transmitted by the bite of the Aedes mosquito. So now you know the importance. You're waiting. When will that Aedes mosquito finally come? The list will come. It's going to be a long list, of course. So remember, Aedes mosquito means that here I'm going to have this condition with the bite of an Aedes mosquito. Fine. So it's going to come to us. But how can it further get transmitted? So tell me, can Zika virus get transmitted from mother to child? Yes. Can it get transmitted via blood transfusion, blood products? Yes. Can it get transmitted via sexual contact? Yes. So remember, these are the three routes of how a human to human contact can occur. Sexual, mother to child, as well as the blood transfusion. So yes, this is where they catch you. So let me pick it up. This means that when you're talking about mother to child, this is the place where they catch you the most in the exam. Mother to child means through the placenta it is going. Which cells of the placenta? One by one, let us start getting here. Mother to child, which cells in the placenta gonna be affected is what they asked you. So please note, these are the Hofbauer cells in the placenta. Hofbauer cells of the placenta are going to have the deposition of the Zika virus. I hope you remember from pathology what were Hofbauer cells. They were macrophages of the placenta. So they show you the deposition of Zika virus. That's a previous year question. So fine. From the mother, this is going to go via the placenta to the child. So what are the two things? Number one, focus on the eyes of the child. Number two, focus on the brain of the child. So eyes mein do cheezein, brain mein do cheezein. That's all that you have to know. So in the eyes, this child is going to have optic nerve problem and glaucoma. So optic neuropathy and congenital glaucoma. Whereas what is it in the brain? Brain mein the size is going to be smaller, skull, microcephaly, but ventricles are bigger, ventriculomegaly. So remember, there is going to be microcephaly and ventriculomegaly noted over here. Repeating, there are two things in the eyes, optic neuropathy that is noted and congenital glaucoma. Two things in the brain, microcephaly and ventriculomegaly. This is what the child has. Which cells are affected in the placenta? Hofbauer cells. But what is the person, an adult or a mother or a person who's transmitted it by sexual contact or by blood transfusion? What is it that it's going to have? So the main, pehle to minor thing. Ma'am, fever, arthralgia, myalgia, ये सब में होता है. तो सब में, this has become like the nausea vomiting of this. Like we do nausea vomiting as a side effect of every pharmacology drug. We do fever, myalgia, arthralgia as a complication of every of these fevers. That's there. But the Zika virus has two main things, and that is a cardiac and a neural involvement. So definitely there are cardiovascular and neural may although rare, but Guillain-Barré syndrome is noted with Zika virus. These two are the main worrisome things that can come down with Zika. Yes. Again, do you want me to tell you the diagnosis? It's going to be the same reverse transcriptase PCR. The diagnosis of the antibodies again going to be IgM antibody. But now you will say that, ma'am, all of these things that you're telling me for flavivirus, सब में you are very nicely saying RT-PCR. ठीक है, PCR तो is genetics. Genetics will always differentiate Zika virus from yellow fever from Japanese encephalitis. Okay, PCR I have full confidence. But how are you so confident that antibodies will not cross-react? If this is a Japanese encephalitis or a yellow fever or the Zika virus, they are belonging to the same family. Can their antibodies also cross-react? Can you have a more definitive test that can help me? So please note, firstly, RT-PCR kaha karoge? I'll give you the answer to that. RT-PCR kaha karoge? Ab depending, Zika virus could involve the blood. It could also be treated in the urine. So in pe karenge. Talking about how do I confirm the IgM antibodies? Please remember, for the confirmation, we will use PRNT. What is PRNT? It is the plaque reduction neutralization test for confirming that I'm dealing with not just over here. We will be doing this in Japanese encephalitis also. We could do this for the confirmation of yellow fever also. For any Flaviviridae member family, because we are relying on this serology more, for the confirmation of that particular organism, we will do a plaque reduction neutralization test. So that finishes off Zika virus also. So the last part of this chapter that we'll start with is the dengue virus, which we know is one of the most common arboviruses and the mosquito-borne infections that we have, especially in India. And this is one of the most rapidly spreading infections. You've heard about it every year. This comes up as a lot of bulk of cases that drop in suddenly. So definitely it's very important from not only micro but also PSM as well as from medicine point of view. So when I start off with how many types does it have, we all know there is DEN 1 to DEN 4. that are available. So now the vaccine also that we have, that is Denraxia, is also something which has 4 protection serotypes, protection against 4 serotypes. But recently Den 5 has also been identified in Bangkok. That is a separate issue, but please remember we have 1 to 4 which is the most common, and Den 2 is the one which is most dangerous. What is the vector? No points for guessing. That of course the vector is going to be the Aedes mosquito, and yes, we have something very similar to Aedes over here which is known as ADE. Now what is ADE? I'll tell you. See, now think of this. There are 4 serotypes available. So for example, this month someone had an infection with Den 1 and developed antibodies against Den 1. Will that be able to protect him or her against Den 2, 3 and 4 in the next month? No, so it's type specific, number 1. Second, please note that if someone has infection with one type of virus and that person develops antibodies, that person is at a risk of something known as ADE. What is this? Antibody dependent enhancement, or also given a lot of names like original antigenic sin or immune enhancement hypothesis. They are basically talking about some enhancement happening over here. So let's assume, what is the meaning of all this? Let's assume someone got infected with one dengue virus serotype, right? Primary dengue infection hua. You will say, ma'am, that person made antibodies against it. So now when he gets a second infection, you know what is going to happen on that second infection? You would expect that, acha, when he had dengue first time, he has developed antibodies. So next time he should not even have the infection, or he should have a very mild infection. But next time he ends up having a more severe infection. Why? Because the antibodies that were going to be formed in the first infection, they will actually team up with the virus the next time. They will team up with the virus and they will protect that virus from the immune system. So the second time you won't be able to mount an immune response and you will not be able to kill the virus only. So simple, it's like a partner in crime, like a teaming up that is done, that whatever antibody was formed in the primary infection, that is actually gonna team up with the dengue virus that has come in the secondary attack. And as a result, it will hide it from the immune system. So you will never be able to attack that only. As a result of which, the infection is going to turn out to be more severe. So is your antibody from the first infection enhancing the second infection? So now you've understood antibody dependent enhancement. So this is a kind of a sin, original antigenic sin or immune enhancement hypothesis that you see with dengue. And what is the vector that I told you? The vector was Aedes, and you must be knowing how, it's quite unfortunate that we've come to that level in micro where we also have to talk about how one mosquito gives the disease to the future progeny. We are also reading about the life and the reproduction of a mosquito. But yes, that's important, that Aedes can give it to its offsprings itself also in the form of transovarian or transovarial transmission. So that is also what we come down to. Now clinically, let's quickly go into it. There are 3 types of dengue that we have to know. There is number 1, what you read in medicine, that is known as dengue fever. The second one is referred to as dengue hemorrhagic fever, where I'll tell you some criteria that are going to be present. The third one is referred to as DSS, that is dengue shock syndrome, right? So these are the 3 that you have to know over here: dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Let us start one by one. Before I start writing things, I think everyone knows how dengue fever presents. There's very high grade break bone fever. You feel as if your bones are breaking because there is so much of muscle pain, joint pain that happens. There's a lot of frontal headache that happens, watery eyes that are going to be there. And what else? You also have some rashes. So I don't think there is anything out of this that you want to mug up, because you probably have had dengue or have seen people around you having dengue. So number 1, there's a very high grade fever. Like I said, it seems as if there's a bone breaking. It's very painful in terms of joint and muscle pain, and also said to be the saddleback fever, which is a biphasic fever, which is also seen with chikungunya. Next, what else do we have? We have rash. As I've told you, there is a maculopapular rash. Why is there a rash? Because dengue fever primarily is a decrease in which cell count? It's a decrease in platelet. So kahan dikhta hai? The first areas where you'll start seeing is the upper part. So it could be the upper part of the chest and the trunk and the upper limbs. That is the area where you would notice it. Next, I've told you break bone because of lots of aches and pains and a frontal headache. That is a very common thing that you see with dengue fever. So dengue fever to ho gaya. Now I'm going to add the hemorrhagic element to it. So whatever I've studied for dengue fever, plus if they say that the patient has had a platelet, hemorrhage kab hoga, bleeding kab hoga, when there is going to be a platelet count of less than 1 lakh, either quantitative problem or there is going to be some functional defect. So see, platelet bleeding will happen of 2 things. Either there is a quantity problem in the platelet. Guys, what is the normal platelet count? 1.5 to 4 or maximum 4.5 lakhs per mm cube is the normal platelet count, right? And they are saying it started falling, but when it falls less than 1 lakh, that is when I'm more and more worried. So platelet count less than 1 lakh or a qualitative defect in platelet is one thing. And also there's a very famous test. We know there's a tourniquet. If you tie a tourniquet, there are going to be hemorrhagic spots noticed. So positive tourniquet test. Also please note, there's another test that we do, that is hematocrit increase by 20%. So what is hematocrit? Hematocrit that you study in pathology is the other name for a packed cell volume, and that has a normal. If I give you a normal male female average nikale, normal is roughly around 45%. So between 35 to 45% you can say. So for example, someone had an hematocrit of 35% to begin with. That female had a hematocrit of 35%. Now she's having a hematocrit of 55%. So the hematocrit has increased. That is again something. Why is that happening? Why? So please remember, this is featuring hemoconcentration. This is an evidence of hemoconcentration that is happening. So what all do you have to know? Dengue fever, hemorrhagic fever mein dengue fever wale all symptoms are there, but hemorrhagic mein you have to know that number one, the platelet count is affected. Second, there's going to be a positive tourniquet test, and the hematocrit is also going to increase by a 20%. Now we come to the third one, and that is dengue shock syndrome. Everything that you had studied up till now is a part of it, but now there's going to be shock. So there's an element of endothelial damage, that is an element of circulatory failure, or you can say shock features that have started coming up. Why? Because an endothelial damage has occurred. So the word shock tells you shock. So overall I realized difficult nahi hai. Dengue fever mein fever and aches and pains related features, hemorrhage mein a lot of platelet count and hematocrit problems, and dengue shock syndrome mein shock related features. So this is a kind of a grading that has been given by WHO, which I quickly wanted you to go through. It seems very busy, very cluttered table. Not very cluttered. Trust me, you know this. You know what is dengue fever? You know these are the three grades, grade 1, 2, 3 of dengue hemorrhagic fever that they've written. And in the end for grade 4, they've written dengue shock syndrome. So overall, I realized that dengue fever is not given any grade. And what are the things? I think you already know. What is dengue fever? Fever with 2 or more of the following symptoms. What are the symptoms I told you? Break bone fever, lots of muscle pain, joint pain, frontal headache, and retroorbital pain. That is what is the WHO criteria for pains. What are the 4 pains they've said? Frontal pain, retroorbital pain, frontal headache wala pain, retroorbital pain, muscle and joint pain. Inme se any 2 or more pains are there along with this fever. That is dengue fever. And what counts do you think is going to be low? WBC count can be low, but what has to be low is the platelet count. Dengue fever में platelet count होगा, but do you have any hematocrit problem over here? No, this is not the stage. There is no evidence of plasma loss. There is no hematocrit problem. That is why it's not given any grade number only. Now let's come to dengue hemorrhagic fever. As soon as dengue hemorrhagic word is used, platelet count to chalo will be low. Platelet count being low is a feature of just dengue fever from start to end. But what is going to be further problematic is plasma loss, hemoconcentration. The hematocrit rises by 20%. So as soon as the hematocrit rises by 20%, I know I'm dealing with dengue hemorrhagic fever, grade 1, grade 2, grade 3. So how do I do 1, 2 and 3? So whatever I studied for dengue fever, if I just add a tourniquet test to it, it becomes grade 1. Further, if I say there's so much decrease in platelet count that the person has started having spontaneous bleeding, that is going to be grade 2. And if there is a circulatory failure in terms of hypotension, weak pulse, that slowly he's going towards shock, that becomes grade 3. So repeating this once again, agar sirf and sirf positive tourniquet test has come, that is grade 1. If spontaneous bleeding has happened, that is grade 2. And if circulatory failure starts happening, so remember PSC, positive tourniquet test, spontaneous bleeding, circulatory failure, that is grade 1, grade 2, grade 3, because once the patient goes into shock, you will call it grade 4, and that is dengue shock syndrome. That is the WHO grading that you have for Dengue. What is the lab diagnosis? Firstly, for everything I do PCR. PCR is usually positive between day 1 to day 7. So it is an early methodology that you have to do. And what is the antigen? Nowadays you even have CART tests. So you even have ELISA. What is the antigen for dengue that we have? We have the NS1 antigen. NS1 antigen is something again which is positive up till day 7. So if someone asks you for the early diagnosis of dengue, you're going to have NS1 antigen testing up to day 7, but usually 3rd, 4th day is the average till which we find NS1 antigen, because beyond that we start finding the IgM antibody. So although textbooks mention day 7, I personally have seen it in day-to-day practice that dengue outbreak happens 4th day tak to you get NS1 antigen, after that you start getting antibody, but books say up till 7 days. So up till 7 days you will get the, up till 7th day you will get the antigen, and after the 7th day you will start getting the antibody, and that is going to be the IgM antibody. I've told you multiple times, IgM antibody is measured by a test called MAC ELISA. That is sorted. What is the treatment? You know, it is all supportive treatment. Whatever the patient is having a problem with, you're gonna correct it. So if the patient says that, or if the patient's blood report says that the platelet count has gone low, very, very low, then you go in for a platelet transfusion. Go to your blood bank chapter in pathology. I've told you, single donor apheresis platelet is always better. Receiving platelet from a single donor only. Single donor apheresis platelet has less side effects. So SDAP is what is preferred. So agar platelet come hai, you give platelet. And if there is hematocrit, if the hematocrit is increasing, that means you are having some kind of plasma loss. And if there is plasma loss happening, you will have to do a fluid replacement. So now next time when you come across a patient of dengue, everyone please note, we always see doctors and many students are prescribing their patients platelet count. Keep getting a platelet count then every alternate day. Is it only the platelet count that you will be doing? No, you will be doing a follow-up with 2 things. Not only are you interested in a platelet count, but you're also interested in knowing the hematocrit. You have to look out for both things. Platelet count come hoga, give platelet transfusion. If the hematocrit is more, give fluid correction. What is the vaccine available? Vaccine for dengue is dengue and vaccine. So dengue raxia, and gives protection against what? Gives protection against all 4 serotypes. That is a previous year question again. It gives protection against all 4 serotypes. That marks the end of this entire chapter of the Arboviridae family, arboviruses that you have. But I had promised you that right in the end, we will make a list of everything to do with Aedes and Culex. So yes, what are the 2 Aedes mosquitoes that you know of as of now? We know there is Aedes aegypti and Aedes albopictus. Do we know it has stripes like a tiger? It's a tiger mosquito and it bites during the daytime. It's a daytime mosquito, fine. I have also told you that it is going to transmit the disease in its family only to its offsprings by transovarial spread, and it has cigar-shaped eggs. So yahan tak to I think I have told you that transovarial transmission happens. I have told you it has cigar-shaped eggs. I know you are interested in knowing what all diseases are transmitted. So remember, Aedes cried. Aedes mosquito is crying. So many diseases have been, so much of responsibility the environment has given on Aedes mosquito that the Aedes is cried. So what is Aedes is cried? Let us start. So Aedes, E and ZZZ. Aise likha Aedes. E means Eastern Equine Encephalitis. Remember the Western Equine Encephalitis was with Culex. So I've told you Eastern Equine Encephalitis. What is ZZZ? Zika virus. Okay, then C and C. California encephalitis, yahan tak to ma'am things which I'll hardly get to see. Chikungunya, the other C is for chikungunya. R for Rift Valley fever, Y for yellow fever, and D for dengue virus. So repeat in Eastern equine encephalitis, ZZZ for Zika, California encephalitis, chikungunya, Rift Valley, yellow fever, dengue. Aedes cried is what is transmitted by the Aedes mosquito. So the last one is what is transmitted by the Culex. So Culex may, please remember, why have I got this emoticon? Because I'm going to give you a kind of a weird mnemonic for it, a cute one. Japanese and Western females are cute. Okay? So Japanese will definitely, so cute, actually cute is going to be for Culex. So that is how I wanted to put up something related to it. So remember, Japanese is going to basically be your Japanese encephalitis, and we all know that all these ones which all have arthritis like features unme hota hai, right? So Japanese encephalitis encephalitis primarily. West for West Nile fever. West Nile fever is also transmitted by culex. And when you will go to your filarial nematodes, Bancroftian filariasis, so female say filariasis. Remember, Japanese and Western females are cute. Cute for culex, Japanese encephalitis, Western for West Nile fever, females for filaria. These are the three main things which you have to know for culex. So I hope Aedes and culex ka summary is also done and all of you have put it down into one thing. I think one more thing you could have done with West before I end. Don't we have something called Western equine encephalitis also? So why don't we add that as well? Although we are hardly going to see that in our clinical practice or even a question, but since we read it, I feel that we should complete the story out here, right? So everything with West is also sorted. Yes, on that note, we wrap up the Arboviridae family. We are now going to start off with some kind of miscellaneous viruses. And yes, after that, I'm going to give you a list of all the viruses that I've taught you which can cause you hemorrhagic fevers.